Welcome back to our fifth guest case in the case review community. Tim Moss here, and this is a case that Raj Valvani, one of our members from Marietta, Georgia, has presented to us. And let's look through this case again and seek some resolution, and then talk about the disease entity. As you recall, this was a 46-year-old male who had a fall from onto the sacrum from chair height and bilateral upper and lower extremity paresthesias thereafter. There was some persistent difficulty walking with numerous falls in 10 days prior to presentation, but no bowel or bladder symptoms. On physical exam, this was most remarkable for the ataxic myelopathic gait. His strength was good with the exception of bilateral EHLs being 4 out of 5. He had some hyperreflexia and sensation was intact, although there was decreased proprioceptive sensation. And just to bring this back to you, this was his gait, which was quite remarkable. So a pretty dramatic ataxic myelopathic gait. And here are the selected images from his MRI. And so the question presented was, these MRI signs and symptoms are pretty strongly suggestive of the diagnosis. And that diagnosis is indeed subacute combined degeneration of the cord. So I'm going to just briefly go back to the MRI and bring that up to your attention, what we're looking at here. And I'm going to bring in the cervical images initially, and I'll bring in the sagittal T2s and the axial T2s. Sagittal T2s are now on your right. And if we go to the midline, we can see a subtle T2 hyperintensity over multiple segments, essentially throughout the cervical region. And when we localize that on the axial images, I'll scroll through these, we can see that that T2 hyperintensity is situated very discreetly here in the dorsal columns of the cord. And you can see those very nice bands of hyperintensity, which correspond very tightly to the dorsal columns of the cord. Maybe a little extension laterally here as well, but otherwise dorsal columns pretty exclusively. Now in the thoracic region, it's a little tougher to appreciate, but I'll bring those sagittal images into the mix here. And when we look at the sagittal images, it's tougher to see. There's a little more motion artifact. You can kind of get the idea there's going to be some T2 hyperintensity dorsally here, but without corroboration on the axial image, you probably wouldn't be able to tell. But when we look at the axial images, and again, there's a lot of artifact here, and it turns out that every other image is really quite nice. But there we see these little 2 dots of T2 hyperintensity, again, in the dorsal aspect of the cord. And that seems to be a consistent phenomenon. Again, looking through the artifact, there's some T2 hyperintensity that has a localization in the dorsal aspect of the cord. Here's another nice example, these 2 little bright dots. And that follows throughout as we go down. Again, T2 hyperintensity localized to the near midline dorsally. And that is very characteristic of subacute combined degeneration of the cord. So what is subacute combined degeneration? Let's talk about that for a few minutes. The pathology here is early on, there's myelin sheath edema in the posterior primarily, and sometimes the lateral columns of the cord. And late, there's myelin sheath loss, leading to axonal loss and Wallerian degeneration in the cord. And the etiology here is vitamin B12 deficiency. Vitamin B12 is a coenzyme, which is critical for 2 major metabolic pathways, particularly the conversion of homocysteine to methionine, and methylmalonyl coenzyme A to succinyl coenzyme A. These are critical for cell metabolism. The etiologic associations, that which underpins the difficulty in myelin formation and myelin maintenance, is vitamin B12 deficiency. This is most commonly associated with pernicious anemia, in which there's a deficiency of intrinsic factor. And this may be an immune-mediated gastric dysfunction leading to an atrophic gastritis, or there may be a number of miscellaneous malabsorption issues where we simply do not absorb vitamin B12. This may include gastrectomy, an ileal resection, Crohn's disease, or celiac disease. Interestingly, there's a strong association with prior administration of nitrous oxide anesthesia. There may be a dietary deficiency as well in strict vegans, and also a copper deficiency in myelopathy, which can essentially mimic subacute combined degeneration and the vitamin B12 deficiency. If we look at a fairly large series here, again, this is not a real common phenomenon these days. This study by Vasconcelos looked at 57 patients in 45 different reports. This was a review of observational studies. 75% of these patients did indeed have pernicious anemia with a deficiency of intrinsic factor and an inability to absorb vitamin B12. About 3% of the patients were vegan. 17.5% had miscellaneous risk factors. Only one patient had no reported risk factors, but 26% had a history of prior nitrous oxide exposure, either anesthesia or recreational use. So how are these patients going to present clinically? Well, very much like our patient. They may have symmetric ascending paresthesias, which tend to localize in a glove and stocking distribution, hands and feet. And that sensory deficit is primarily going to be proprioceptive, inability to understand position in space, and lack of vibration sense. There may be a discrete spinal level, anywhere from C2 to T11. Weakness can be present and can progress to spastic paraparesis, either quadriparesis or paraparesis. As we saw in our patient, ataxia with gait abnormalities are a typical presentation. It can be widely varied deep tendon reflex abnormalities. A very common phenomena is a dissociation of upper and lower extremities with hyperreflexia in the upper extremities and hyporeflexia in the lower extremities. And this may indeed progress to cognitive impairment with significant cognitive decline. What are we going to see on imaging? As we saw here, it's pretty characteristic. There's T2 hyperintensity in the spinal cord dorsal columns, much more commonly than the lateral columns. In the cervical cord, we're going to see this inverted V or inverted rabbit ears, which we see right here with these bands of T2 hyperintensity localized to the dorsal columns. In the thoracic cord, we tend to see paired focal rounded zones of hyperintensity, sometimes referred to as binoculars, as we see down here, just two little white spots in the dorsal aspect of the cord. And on the thoracic area, that could be very difficult to see in on the sagittal image. On T1 images, we may see slight cord enlargement, which we may be able to localize to the dorsal columns with some associated hypointensity. If we give them gadolinium, there may be a patchy enhancement or no enhancement at all. And anemia patients may have diffuse T1 marrow hypointensity. Occasionally, we're going to see T2 hyperintensity involving the anterior column or the full thickness of the cord, but that's a rare phenomenon. Now, even though that's a very characteristic appearance, that is the T2 hyperintensity in the dorsal columns, it's not necessarily that sensitive. In one study with an N of 54, all of whom had a clinical diagnosis of subacute combined degeneration, the MRI showed that characteristic finding only in 15% of patients. So don't rely on the MRI finding being present. In that cohort of patients, there was no correlation between the imaging findings and the clinical severity of disease expression. But there was a clear-cut negative correlation between the measured B12 levels and the disease severity. Low B12, bad disease. Just to review our case, here we have the characteristic findings of T2 hyperintensity in the dorsal columns, some extension laterally, and in the thoracic area, these little dots of T2 hyperintensity, the little binocular sign. Some other examples from the literature. Here from a case series, we see the T2 hyperintensity in the cord on the T2 weighted sagittal image. And there are nice hyperintense bands, very much confined to the dorsal columns. And on post-treatment images, complete resolution of the imaging findings. Another case from that article, again, patchier T2 hyperintensity, little less discrete in the dorsal columns, but again, complete resolution on post-treatment images. From another case series, T2 hyperintensity in the dorsal aspect of the cord near the midline. A little tougher to see on the T2 sagittal image, complete resolution after treatment. And a final case example from the literature. Here, it's not so discretely in the dorsal columns. It's a little more centric in the cord, patchy T2 hyperintensity over multiple segments, which resolves after therapy. So the imaging differential diagnosis, other things we might consider would include spinal cord infarction. This is going to have generally a very hyperacute presentation with primarily motor, not sensory symptoms. And when we look at the imaging, we're going to see T2 hyperintensity in the ventral cord, not the dorsal cord. It'll involve primarily the central gray matter. We may have inflammatory demyelination, particularly with multiple sclerosis or acute disseminated encephalomyelopathy. And here, these are patchy focal lesions in the cord white matter, but not necessarily a predilection to the dorsal column. So we'll often see involvement, particularly of the lateral columns. And again, this has a very classic clinical relapsing remitting course. Infectious myelitis can be a real conundrum because HIV vacuolar myelopathy can essentially be indistinguishable on imaging from subacute combined degeneration of the cord. And Lyme disease and zoster involvement of the cord, again, can be very similar to our current case. Spinal cord contusion, we should see imaging findings of trauma and, of course, the history. And acute transverse myelitis is going to be a diffuse holocord swelling, not localized to the dorsal columns, and, of course, an acute presentation. Some examples here, a nice case from my colleague, Dr. Dean at Mayo. This was a case where we see T2 hyperintensity in the ventral aspect of the cord in this patient who has a cord infarct. And here are multiple segments of subtle T2 hyperintensity in the ventral, not dorsal cord. And then a few days later, developed T2 hyperintensity in the vertebral body. And this was a young patient, a 29-year-old with a very sudden hyperacute onset of lower extremity weakness. And this is probably due to a fibrocartilaginous embolism, where there's an embolism of fibrocartilaginous disc material into a radiculomedullary artery, which subsequently goes to the ventral aspect of the cord, to the anterior spinal artery distribution, not to the dorsal aspect of the cord, the dorsal columns, and also may involve the blood supply of the vertebral body. Hence, we may see involvement predominantly of the ventral cord as well as a vertebral body infarct. Here is a typical case of multiple sclerosis where we have patchy involvement of the cord, multiple levels, both ventral and dorsal, and a typical localization into the lateral white matter of the cord, not necessarily localized to those dorsal columns. Another example from the literature of multiple sclerosis, patchy involvement here on a proton density image, a little more discrete on a T2 weighted image, and then on a stir sequence, more discrete with some slight swelling when it's in an acute phase, but multiple foci, not limited to the dorsal aspect of the cord. Here's the challenge we have imaging-wise is here's HIV vacuolar myelopathy, and it can look almost essentially identical to our case of subacute combined degeneration. Hopefully history will discriminate, as will the laboratory findings. So how do we treat this? Well, we replace vitamin B12. In the clinical response, essentially all patients should arrest any progression of their neurologic deficits. In the largest review, this Vasconcelos review of all observational studies, 86% improved, but only 14% had complete resolution. And of the patients who had complete clinical resolution, only 5 of 8 had complete radiologic resolution of their imaging findings. So there may be some dissociation of clinical response and imaging response. In a few patients, the radiologic findings normalized despite there still being some clinical sensory deficit. Predictors of complete symptom resolution in that large series, the absence of a sensory level, absence of Romberg or Babinski signs, absence of cord atrophy or anemia were positive findings suggestive of complete symptom resolution. Male patients did better. Those who had a positive Lermite sign or age less than 50 or who had a lesser duration of disease expression were more likely to completely resolve their symptoms with B12 therapy. Imaging predictors of complete symptom resolution were involvement of less than 7 cord segments, and interestingly, the presence of cord edema or presence of enhancement, which would suggest we're catching this early in the subacute inflammatory state before we've moved on to more axonal loss and Wallerian degeneration. So to summarize, subacute combined degeneration of the spinal cord is a disease of B12 deficiency. It has an insidious presentation with primarily sensory deficits and gait ataxia. It may progress, if undiagnosed, to spastic paresis and cognitive decline, so we want to make this diagnosis. Clinical associations are primarily pernicious anemia, malabsorption syndromes, vegan status, or nitrous oxide anesthesia or recreational use exposure. It has characteristics MRI features, that is T2 hyperintensity in the posterior columns of the spinal cord, which are specific but may not be sensitive. And if we can make the diagnosis with laboratory confirmation, essentially all those patients will improve on therapy, but only a minority are going to achieve complete resolution of their neurologic deficits. So I'd like to thank you very much for your attention, and my particular thanks to Dr. Valvani for bringing this case to us and presenting it for us. And we'll look forward to the case review community bringing additional cases to us. We're always looking for good and interesting cases to work up and bring to your attention so we can all learn. So stay safe out there, and we'll look forward to seeing you again soon. Take care.